Okay, we're gonna get started. Last people coming in, you can take us. Oh, there's Frank and Elise. Great. Great. Good morning. Thank you all for being here. I'm really excited about the day. My name is Becky Slodek. I'm the Administrative Director of the Garvey Institute for Brain Health Solutions. I'm going to go through real quick some housekeeping things before the main event starts. So, number one, if you haven't figured out where the bathrooms are yet, when you leave this auditorium, you take a left and they're all the way down the hall on your left. That's where the bathrooms are. If you want to hang up your coat, looks like people figured that out, but there is a coat rack right around this corner to your right. At the front desk, hopefully you all checked in, you got your name tags. If you want a printed agenda, they're at the desk. There's also Wi-Fi password. If you need a Wi-Fi password, we have that at the desk as well. No food or drink in the auditorium, which that seems like the big no, it's fine. Just I don't see any food. Just you know, keep yourself clean, keep your space tidy, and take it out when you're done. That would be helpful. We are recording this meeting, and there are friends on Zoom. So people are watching. It's a hybrid event. We are recording it. It will be available, the recording and PDF of the slides and everything on the Garvey website, probably this afternoon or tomorrow. If you drove here and want your parking validated, also at the front desk, you will get you have your parking ticket, and you'll insert your parking ticket, and then you'll scan a QR code. And that will pay for your parking. So if you want your parking paid, make sure you visit us at the front desk and we can help you through that process. And then lastly, if we have time at the end of this morning session, we're gonna have comments. If you're on Zoom, you can type your comments or questions into the Q&A and I will be monitoring that. And if you're here in person, we'll have microphones and we'll be able to pass those around for people who wanna comment on what they've heard today. That'll be at the end of the morning session. People on Zoom, the afternoon session is not on Zoom. So we'll say goodbye to our friends on Zoom at noon. And then if you have any questions or need any help about anything, people with yellow name tags, such as myself, are available and free to help. So with that, I will introduce the director of the Garvey Institute, Jürgen Unitzer.
All right, good morning, everybody. It's great to see you all here. I'm Jürgen, and this is the third time we're meeting for an annual meeting to take a look at what we're doing at the Garvey Institute for Brain Health Solutions. And everybody here has some role to play in that, so it's great to see you all. I'm gonna just give you a little preview of what we're gonna do together. I'm gonna give some opening comments, just give a very high-level overview of some of the things we've been working on this year. And then we're going to hear from some of the folks who are doing the work in a bit more detail. The first thing we're going to hear about is a new program we started this year called our Clinician Scientist Training Program. The second presentation we're going to have is on a whole new way of treating people who are living with serious mental health problems, and that is a group of treatments that we summarize under the term interventional psychiatry, and then within that there are some treatments that use neuromodulation. And for those of you who know what that is, you'll hear a little bit more about it. For those of you who have no idea what I'm talking about, you are going to get a very gentle introduction to what is neuromodulation. And then we're going to take a little break. And then we're going to do one last set of presentations, and that is going to focus on what are all the ways in which we, who are working in this field in helping people with mental health and addiction problems, can better engage with and support the families and caregivers of people living with mental health and addiction problems. And that's it. We're going to have a bunch of people coming up here giving talks. We'll have some time at the end for some closing comments, and then we're going to have a lunch, and the lunch is going to be up there where you came in. All the way at the end, we're going to set up a really nice lunch buffet. You're welcome to join us. And then for those of you who are interested in that, This afternoon, we're going to do a little workshop on how do we go about developing new research centers in the area of new treatments, novel therapeutics. We're going to have two of our colleagues here who've spent the last couple of years trying to build a new research center, and they're going to share some of their experiences. And those of you who are doing that work or who are a little earlier on, maybe we can exchange some ideas. So that's really a workshop, and you are welcome to attend that, or you can join us for lunch and say that was good. Going home. All right. So that's the plan. Before I start, I want to remind everybody why we are here, what makes it possible for us to be here, and that is, the Garvey Institute for Brain Health Solutions was started with a big foundational gift in the fall of 2019, and that gift came from Lynn and Mike Garvey, and the Garveys are here today. And in fact, we have actually, I realize we have 3 generations of the Garvey family here with us today. Lynn and Mike and Denise, their daughter, and Owen, their grandson. So I want to thank all of you for this wonderful gift that makes it possible for all the rest of us here to do this really important work. And the promise I made Mike and Lynn, when we talked about starting this institute, is I said, we're going to put together the best minds in the Pacific Northwest to do 3 things. Most importantly, we're going to go about seeing what we can do to improve the lives of people and families who live with brain health and mental health problems. Secondly, we're going to try to see what we can do to find better treatments for tomorrow. I think we have some good treatments today. They can help a lot of people, but everybody here knows that we need better than what we have today. And then the third thing is, and we're going to hear a lot about that today, we will set out to try to inspire and support the next generation of people who are in science, of people who are healthcare professionals, to convince them that caring for people who live with brain health, with mental health problems, is the single most important thing they can do. So the one thing I do is I chair the Department of Psychiatry at the University of Washington. And in UW-Medicine, we have 31 departments, and everybody competes for the best people, not just for resources. I'm having to compete with cardiologists and neurologists and cancer doctors, and everybody thinks their thing is the single most important. And when we have students who are talented, promising young people, we have to find a way to kind of to show them what's possible when you help somebody who's struggling with a mental health or addiction problem. And so it's not just a matter of resources, it's really a matter of the talent. How do we convince the people who are coming new into the healthcare professions that working with people who have mental health and addiction problems is the single most exciting thing that they could possibly do with the rest of their lives? So that's that third bullet. And I think that I feel actually very good about, because there's a few of us, when some of us got into this business, some 30 years ago, it was not sort of the most celebrated part of medicine. There was still a lot of stigma tied to mental health and addiction problems. We didn't know that much about the brain. And I feel sort of a little bit like we were tapping in the dark and saying, there's got to be something that we can do here. And that has changed. That has really, really changed. Now we are starting to understand much more about the brain. We have seen treatments that have really changed people's lives. And I think that gives us sort of the excitement to say, what can we do in the next 10, 15, 20 years to really make a difference here? So that's the goal I set out. If you'd like to learn a little bit more about the Institute, we have a really nice website. And we have a mission statement. We have some vision statements up there about what we think is possible to do with that. And I'm not going to read that to you this morning, but you're welcome to look at the site. I think it has a pretty nice summary of what it is that we're doing together. And the other thing I want to do is we have a great community advisory board, and several of our advisory board members are here this morning. So I want to thank you all for helping, look at us from an outside perspective. There's a bunch of us who are on the inside, but giving us a perspective from the outside about, how does this look does this make sense, from your perspective? And so I appreciate all your thoughts, all your input, and all your support. And then finally, I want to thank our great Institute staff. You've met Becky, Andy Uemoto is here, and Mary Piper is here. And we have great support from Kirsten Jones and tech support from Mike Walker. In fact, Mike is the wizard behind the fact that we have a bunch of us here in person, but also a bunch of us on Zoom. And I appreciate everyone's help. All right. We also have one of the strengths we have at UW is we are a very large university. We're the single largest university campus on the West Coast. We have a tremendous faculty with a lot of depth. And so everything we are tackling, we're taking on in the Institute. We can turn and look back and say there is 10 or 15 people who already have a ton of expertise in this areas. So we have a great group of faculty advisors, and I want to thank all of them as well. So a couple of quick slides, just to ground us. Why are we taking on this problem? So just a couple of numbers. One of the sad facts about Washington State, as beautiful as it is and as great as it is, and I love the state of Washington, is we cannot brag about having the most healthy population when it comes to mental health or addiction problems. In fact, if you look at national surveys, we have one of the highest rates of mental health and substance use problems in the United States here in Washington. 1 out of 4 Washingtonians are going to be affected by a mental health or a substance use problem at some point in their lives. And half of those, it will be apparent by the time the person is 14 years old. And 75% of people who will live with a mental health or addiction problems will present by the time they're 24 years old. And that makes this set of health problems very different from many other health problems. So if you think about heart disease or cancer or degenerative brain diseases, those come at us, for most of us, when we get into our 60s, 70s, 80s. These problems, they're coming at us very, very early in life. And if we don't find a way to help somebody with that, you're living with that, struggling with that for the rest of your life. So that is, I think, a big difference. Couple more numbers. During the pandemic, the Center for Disease Control started doing some routine surveys at a population level of what the mental health of populations is. And one of these surveys, very recent, 12% of adults living in the state of Washington, that's about 1 million people, reported that over the last month, they had more than half of their time spent in poor mental health. And 1 in 5 completing these surveys meet criteria for a substance use disorder in the last year. So these are not rare problems. These are problems that are very, very common. And what does it mean when we have a person who is struggling with a mental health or addiction problem? Just a couple of numbers here. We now know that poor mental health is the single largest driver of not being able to do the things you want in your family, in your job, in school. It's a tremendous cause of disability, both here in Washington, but really around the world. And if you look at the numbers carefully, there's 5 times more people disabled from mental health or addiction problems than people who are struggling with things like diabetes or heart disease. There's 15 times more health-related disability that comes from mental health or addiction problems than from cancer. Now, you might say, how the heck is that possible? Cancer is a terrible thing. It could even kill me. That's true. But as I said earlier, most of us, there are some children who have cancer, and that's terrible. But for most of us, if we're going to have our life sort of impacted by cancer, that'll happen when we're in our 70s and our 80s. With mental health and addiction problems, it starts in our teens, in our 20s. And the cumulative burden of these problems becomes enormous. There's also some huge economic losses tied to mental health and addiction problems. But I think we are now increasingly recognizing this isn't just something that is disabling, it's also killing people. We now have in the United States, somebody dies from either a drug overdose or a suicide every 3.5 minutes. I put up there 5 minutes, but I checked this data last night. every 3.5 minutes, somebody in this country dies from a drug overdose or from suicide. And the people who do live with serious mental health and addiction problems, on average, their life ends 15 or 20 years, sometimes even 30 years younger than other people. So it's not just something that sort of makes your life miserable. It can also shorten your life. So probably the most important thing is, as I said, this is not something that's rare. I'm maybe a little bit biased. I'm a psychiatrist, but I don't think I've ever met a family where there isn't somebody who's been affected by a mental health or addiction problem. So this is a problem for all of us to care about. One of the other things I can say, and I'm not proud of this, I think this is a huge challenge for us, is most people who have cancer will get cancer treatment. Most people who have heart disease will get heart disease treatment. Fewer than half the people who live with a diagnosable mental health or addiction problem will get any kind of treatment at all. We still have a long ways to go to get people treatment, and more importantly, to get people effective treatment. And there are a lot of reasons for that. So one of the ways in which these disorders are really different from other health problems is sometimes the mental illness or an addiction in and of itself makes it hard for people to appreciate that they're struggling, that they need care, that they should seek help. That's different from anything else. People who have cancer aren't, sometimes we like to deny it, but for the most part, we see we got a problem, we got to get help for it. True with heart disease and most other health problems. If you're in pain, if you're struggling, people will say, I need to get some help. Many of the folks we take care of, are not, they're struggling enough with the mental illness itself or with an addiction problem. It makes it hard for them to get help or to keep showing up and to actually take the help that's offered. Other things that are in the way are there still is a lot of shame and fear related to mental illness and addiction, and that can get in the way of people or families looking for help. And then I think historically, if I look back, this has been an area of medicine where people just have sort of treated it as a second-rate thing, as a second-class thing. We've not ever paid enough for people to work in this field. We treat people in conditions that are kind of scary. I mean, if you look at some of the sickest people with mental illness in our state are at Western State Hospital. That's a hospital that wasn't built as a hospital. It was an old army fort that was built in the year 1871. And sometime in the early 1900s, the US Army said, these buildings are too decrepit. They're not fit for hosting healthy young soldiers. So what do we do with it? We turn it into a state mental hospital. That's so different. And if you go and see what it looks like to get care in a place like that, if I show that to young people who are coming into medicine, who are becoming nurses and doctors and other kinds of healthcare professionals, they're going to look around and say, whoa, do I want to spend the rest of my life in a place like this? So I think this is an area of medicine that people have been really neglecting and grossly underinvesting in. And I think that's made it challenging for us to recruit enough people to work in this field. So as a result, most of the counties, about half of the counties in the state of Washington, for example, don't have a single psychiatrist, psychologist, or social worker. They don't have anybody who's got any formal training in helping somebody with a mental health or an addiction problem. That's a challenge. So it's not just money, it's not just facilities. People is a really big challenge for us. And I think we'll hear a couple of ways in which we're trying to take that on as well. So, so far, all I've done is told you about some really horrible problems that we're up against. So what about some ways to try to fix that? So what we're going to hear about this morning is really 5 strategies that we've used this year, in the last year, as part of the work of the Garvey Institute to try to go up against some of these challenges. And I'm going to sort them sort of into 2 buckets. The first one, like I said, is really about how do we inspire and support the next generation of scientists and healthcare professionals to work together on taking on this challenge. And there are 3 things specifically that you're going to hear about. The first one is we said, we are going to set out to recruit some really smart, really experienced scientists and clinicians to help lead our work in this area. And you're going to hear from some of the folks that have joined us to do that. The second one is we're going to go about developing and supporting a whole group of new clinicians and new clinician scientists to join us in this work. And the third one is we said, it can't all be just doctors and scientists, you know, who all else can we engage in helping us work on this? And so you will hear about some efforts that we're setting out to engage and support family members and caregivers as part of the healthcare team. And I'll say a little bit more about why I think that's really important in a bit. And then the second set of solutions has to do with this notion of we need better treatments. You're going to hear about a program that we sponsor through the Garvey Institute called Innovation Grants. We've done 48 of these innovation grants. You're going to hear about some of them. These are 48, I think, super promising ideas about what is it that we can do to stimulate out of the box thinking, some new ideas about how we can go up against this problem. And then the last thing is we are about to open up, and you'll see a picture of that in a little bit here, a brand new institute, a brand new center in our new hospital, our new Center for Behavioral Health and Learning that will focus on a new set of treatments called neuromodulation treatments, and you'll hear a little bit about that too. All right, so that's what we set out to do. One of the wonderful opportunities we've had with the Institute is, we were giving funds to support 5 endowed professorships. An endowed professorship is a set of resources that we can award to a very experienced faculty member to help lead a part of the work that we're doing in the Institute. And we have 5 of these endowed professorships. We've awarded 3 of them. I think all 3 of our endowed professors are here today. You've met some of them at last year's meeting. I think you met Tom and Marco, and this year Jesse Fan is joining us. He's the latest person to join us in one of these endowed professorships, and you're going to hear a little bit from them later today. And we have 2 active searches. One of them is for a very experienced senior faculty member to help us work in this area of neuromodulation. And the other one is an ongoing search we have to find somebody who is going to help us sort of charge our work in the area of trauma and brain health. And hopefully when we get together next year, we can introduce 2 new people. We've started some research centers. We started a brand new center for novel therapeutics in addiction psychiatry. Nathan Sackett is one of our faculty members who's leading that effort. I think you've heard a little bit from him. They're doing some, I think, really interesting work on what is the role of psychedelic substances in helping people who are struggling with addiction problems. That's an area where there is a ton of heat right now and not much light. And I don't want more heat, I want more light. We're, I think, making a really smart, thoughtful, careful investment in this area. And I think it has a lot of potential. And the other one is our Center for Medication Development for Substance Use Disorder. Marco Pravatoni was here with us last year. Marco came to us from the University of Minnesota with a crazy idea, which I think is fascinating and interesting. And that is the idea of, could we develop a vaccine that would help people not want to use addicting substances, or to help people who are using addictive substances for those substances not to be such a powerful force in their life. And I think that center has gotten a tremendous amount of traction and a whole bunch of federal funding after some initial investment here from the Institute. So I'm super happy about that. Jesse Fan will talk a little bit about a new program we started this year called the Clinician Scientist Training Program. And I'm not going to look at everything that's on the slide here, just to say, and Jesse will say that in a more detailed way, most doctors spend very little time thinking about research, thinking about new treatments. In fact, the data we have show us that fewer than 1% of doctors devote even 10% of their time to research. And that's something I think is a real missed opportunity, because we have a lot of people doing research in labs that have never seen a patient. And you need a handful of doctors to kind of connect all of that interesting science to what's happening in the clinic. Because otherwise we're going to come up with all kinds of interesting things that nobody can use or will use. And so we're investing specifically in clinicians to do research. We set up a really nice clinical trials consultation and technical assistance program. We have a couple of faculty who are really good at this, and many of the young clinician investigators that we have they have good clinical training, but they don't have the research skills to be able to really do this. And so we want to give them some very good, smart support to say, when you're testing an idea, these are the things you need, and we're going to help you on how to do that. We have a brand new training program in an area that I think has a tremendous amount of promise. So a lot of what happens in brain health, in mental health, lives at the interface, clinically lives at the interface between what psychiatrists do and what neurologists do. Mostly that's a friendly interface, but there's a part of psychiatry, and if you wish, a part of neurology that we call neuropsychiatry or behavioral neurology, that is really about a deep understanding of what actually happens in the brain when people have unusual thoughts, unusual behaviors. And how do we take that knowledge and turn it into better treatments? And so we are fortunate to have started a brand new fellowship program in behavioral neurology and neuropsychiatry here at UW. We have our first fellow who is going to be joining us from New York. That's Kalania Jimenez. We have our program director, Michael Schrift, an associate program director, Mike Personaire. Michael is a psychiatrist. Mike is a neurologist, and I think it's a really wonderful opportunity to have people from two disciplines working together on training the next generation. So I'm very excited about this program. I understand from Michael, we might have a second fellow. Is Michael here? Where is he? He's up there, right? Looks like we might have a second fellow. So we'll have one fellow who's a psychiatrist and one fellow who's a neurologist, and I think that's just great. So thank you for helping stand that up. And then this a couple months from now, we're going to have the opportunity to open our brand new Center for Behavioral Health and Learning. We'll start that in April. The big opening will be actually in May, but we're actually going to start seeing patients who are getting neuromodulation treatments in our new facility in the middle of April. This is a $250 million investment from the state of Washington. Almost 200,000 square feet, a beautiful new building located on our Northwest campus with 150 beds for people with serious mental health and addiction problems, but also patients who have mental health problems and need other care. So people who have mental health and cancer, people who have mental health and other health problems, because that's another challenge we've had in our field. We take the mental health problems and sort them out and put them in a bucket somewhere else. We don't think of it as it's like part of the rest of health. This facility, we're going to be able to treat all of a person's needs, mental health needs, medical needs, surgical needs, and we will have in this new facility a beautiful new state-of-the-art neuromodulation program. That program will be named after the Garvey Institute. It will be the Garvey Institute Center for Neuromodulation. We're going to open it in April of 2024, and you'll hear a bit more from Randall in a couple of minutes about what we're going to do there. But the short of it is this will be the first place in the Pacific Northwest where we're going to be able to offer state-of-the-art neuromodulation treatments such as electroconvulsive therapy and transcranial magnetic stimulation, all in one facility for inpatients, for outpatients. We're going to be able to do some really innovative clinical care, but also really innovative research there. So I'm very, very excited about that. All right, and then finally, as I said, we are investing now seriously in efforts to try to say, how do we help engage and support families and caregivers? And you'll hear a little bit about that work from Molly. Finally, we also want to make sure we're not just teaching doctors and psychologists and other kind of healthcare professionals and family members. We want to be able to provide some education about behavioral health problems, mental health problems to a broader audience. So in our department, we sponsor a series of Grand Rounds talks. We do that every Friday. I can't read all of these, but you'll see there's a whole range of topics that we've covered just in the last year. The Garvey Institute supports these talks. They're open to the public. If you see anything on there that you said, oh, that's something I'd like to learn more about, they're all on our website. You can watch them all. We archive them all. So I think it's a really nice resource. Finally, as I said, one of the things we are doing in the Institute is we're investing in new ideas. So we set out to give a bunch of grants. What is a grant? For those of you who've never applied for a grant, it's a bunch of money to chase an idea to see, is this going to work out? And in fact, it's a bunch of real money. So what we have done is we have given 48 grants so far to 103 faculty investigators. And when they apply for the grants, they have to make the case to us that their idea can have a substantial impact on brain health. They can improve brain health, not just for an individual, but ultimately at a population level. That what they're coming up with could be rapidly translated into clinical care if it turns out to work. What we're giving them is $100,000 to make a proof of concept that's good enough where they could then go and get additional funding. That funding could be from the federal government, from the state government, from a company, where are we at with that so far? So we've given 48 grants to 103 faculty investigators, and they're not just in our department. They are from all 3 UW campuses. So we have grants in Tacoma, in Bothell, in Seattle. They're from 10 schools and 25 departments. The grants are working with a whole bunch of local and regional partners. And how are we doing with that so far? So a couple of ways to think about that. So this initial investment of $100,000 for each of these ideas, and some of them are a little smaller than that, from a purely financial perspective, and this is for Mike, who's a business person, for every one of those dollars we've spent so far, we have now had 5 times the return in additional funding from state grants, from federal grants. And so from a purely financial perspective, people have turned these initial grants into a whole bunch of additional funding. So far, my best calculation is we have sort of, for every dollar we've spent on this, we're getting $5 in new funding into the system. But people have done other things. We have a ton of interesting publications in scientific journals. We have people presenting at conferences. We've had a whole bunch of new grant applications, and we've, I think, created a whole bunch of collaborations that I think over the next couple of years are going to pay us some really big dividends. We've had some really nice media coverage. All of this stuff I'm showing you, if you'd like to see this, as Becky said, we're happy to share that with you in these slides. I'm going to say just a word or two about the most recent series of grants. So this year, we awarded a bunch more of these innovation grants. These are the folks who are our awardees. You aren't going to hear from all of them. You're going to hear from a few of them this morning. And this year's innovation grants had a theme, and the theme was show us an interesting partnership that you as a mental health person could take to develop to have us help reach more people and have more of an impact. So it's a leverage kind of partnership kind of a theme. And the grants we awarded, we had a whole bunch of interesting applications. We can't fund all of the ideas that come our way, but the ideas we did fund proposed some really fascinating partnerships. So some people proposed ways of partnering with families and caregivers. Some people said, what about pharmacists? A lot of people, are, what if we had pharmacists who could be more involved in treating some of our patients in a smarter way, in tracking people who are taking medications? What about coaches in sports teams that have a lot of access to young people? What do they need to know about mental health? And when somebody is struggling, what is it that we could do partnering with them to help a person? What about people who are in law enforcement? I think we all see this, or we can certainly, appreciate it. When a person is in trouble, struggling, sometimes the first contact you have is not with a mental health professional, but it's with a police officer. And our police officers aren't skilled. They're not that skilled in working somebody who's really disturbed. And so a couple of these partnerships are proposing some really creative ways of having us mental health professionals working with people in law enforcement to try to make things better. We have some partnerships that work with people who are in supported housing programs, and we have one that's really interesting, which is with one of our tribes, with the Quinault Indian Nation. And I can't give you all the details. There's a great story behind every one of these ideas, and we have a little bit of a summary in the binders that we share, and we're happy to share more about that. But the bottom line, and I see I'm already 5 minutes over my time, we're off, I think, I'm totally biased here. I think we're off to a great start. I think we are building a great team. We have started to, and we're continuing to recruit some of the best and brightest scientists and clinicians to join our work here. I think we are starting to bring some new therapeutic solutions to our community. Starting in April, we'll be able to offer some treatments that we have never offered here before. And I think we're going to continue to invite and support, hopefully, out of the box, new ideas to say, you know, what we have now is good. What could we have tomorrow? And not every one of these ideas is going to pan out, right? This is why we're calling them innovation grants. We've given 48 so far. I think if a third of them pan out, I'll be very happy. We're going to learn from all of them. So many of you who are here, you're having one of these innovation grants, and I'm expecting that yours is the one that's going to work out really well. But I'm also a scientist, so I also know that not everything we try in science works out. And as long as we learn from it, I think it'll be really great. All right, so with that, I'm just going to say one more big thank you to the Garveys, but also to all of you, to our advisory board members, our faculty who are working on this project, and all of our innovation grant awardees for what I think in 3.5 years has become a big body of work that I think has a chance to make a huge difference. So with that, I'll stop my comments and I'm going to hand over to Jesse, who is going to talk a little bit about this idea of training more clinicians to be clinicians and scientists. All right, you're on.
Thank you, Jürgen. Yeah, I appreciate the opportunity to talk a bit, very briefly, about the Clinician Scientist Training Program that I'm very excited about, and tell you a little about why I think this is an important program, and briefly tell you about some of the exciting things that we've already started since its launch about 9 months ago. So a clinician scientist is a healthcare provider, very generally, who is actively engaged in both clinical practice and research. And that can take many forms. Unfortunately, the workforce for clinician scientists, as Jürgen already pointed out, has not kept up with advances and funding in clinical research. And why are, let's see, here we go. Why are clinician scientists important? Well, if you think about our innovative healthcare system and the treatments that we get when we go to the doctor, many of the discoveries were discovered by clinicians asking very important clinical questions and developing important hypotheses that are testable, and then taking discoveries and translating them back to clinical practice. And so in general, this is why I think clinician scientists are so important. Okay, what, there we go. Okay, so this is a graph that shows in general the decline in people going into, trainees going into research. This is the number of PhDs and MDs who are applying for federal loan repayment programs, which is an indicator of people, trainees going into clinical research. And as you can see, a really steady decline in both PhDs and MDs, particularly MDs. And I can guarantee you that this is not because the cost of medical education has gone down. A really, really problematic situation here. And this is a graph that shows that among MDs who are getting federally funded grants to do really kind of meaningful and large studies, the age of the grantees, the people who are getting the grants, has gone up significantly over a course of 10 years. So we're not funding younger people, we're funding older people who are going to age out in their careers. At the University of Washington Department of Psychiatry, we're lucky that we have a really robust brain health and behavioral health research programs. And unfortunately, most of our students and most of our trainees don't engage in research during their time here. We also have an incredible group of researchers and role models in our department, but also, unfortunately, most of those researchers, because of competing priorities and demands, are not having much contact with our trainees. So our trainees are not benefiting from face time with our amazing researchers. And so we really have an opportunity and a challenge to leverage our amazing clinical and research training programs to help our clinician scientists develop. So our mission for the Clinician Scientist Training Program is to very simply help develop clinician scientists by identifying, engaging, and supporting students, trainees, and early career faculty in their research. And again, huge thanks to the Garvey Institute, the Caton Foundation, as well as other supporters for supporting this important work. So what are some of the strategies that we've developed? And I'll just go through these very quickly, and happy to talk to anyone who wants more details. Number one, we want to be evidence-based in our approach. So we want to assess the needs and assess our outcomes on an annual basis to make sure that we're doing the right thing, and we're open to ideas from anyone who has ideas that will help us. We also want to engage our students, trainees in having contact with our researchers throughout the continuum of their training. I think that's really important. We also want to provide opportunities for research funding for our trainees, and we'll talk a little more about the Trainee Research Awards that we just recently funded, and Jürgen mentioned the Clinician Scientist Consultation and Technical Assistance Program, which will be really, really helpful. We want to help people, help our trainees really understand how to get involved and become involved in their careers, and help them with navigate that transition from trainee to faculty. Very importantly, we want to be able to connect our trainees to mentors and research projects that they can get involved in. This is super important, and we're beefing up our website. We're going to have a number of projects to really improve these connections. And then finally, we have to support our mentors. We have to provide them some incentives and some support so that they can carve out time to spend helping our students and trainees and early career faculty. So these are kind of the core strategies that we've developed for our program. And you're going to be able to hear from 3 of our 10 awardees from our initial round of Trainee Research Awards that we've invested over $150,000 in, and really excited about the diversity and innovation of these trainee awards. So I'm going to stop here, and I think Jürgen, you're going to talk a little more about this.
Yeah, thank you, Jesse. Jesse is Jesse is one of our new endowed professors. He's a wonderful example of a clinician scientist. We've been working together for 30 years, and Jesse has for 30 years been both a good doctor, taking care of some really sick patients, but also continued to do science. So I think we have a couple of examples of really accomplished clinician scientists, and this is what we're hoping to do, is help inspire the next generation to do this kind of work. I'm going to ask Jackie Hobbs to come up for a minute. Jackie is a clinician scientist, and she's also our director of our residency program. We now have the largest psychiatry residency training program in the United States here in our department. And we were fortunate enough to recruit Jackie from Florida to join us to direct that program. So I asked her to give a couple of comments from the perspective of a training director.
Thank you, Jürgen, and good morning to everybody. Really grateful to be here, have a chance to talk with you. As he said, I am the director of the General Adult Residency Training Program. As a program director, I can't do anything without talking about ACGME requirements. So, that's our accreditor. That's, how we keep our program going. And some of the things are that we must have our residents participate in some kind of scholarship. And really, and we have to have resources for them and opportunities. And a big part of that is to make sure that every resident who leaves our program is able to, read the literature, understand it, translate it for patients to help them understand and help guide them in their medical decision making. So we really have to be thinking about the fact that, the future is now. So 2040 may seem a long way away, but it's really not. And the trainees who are graduating right now are the ones who are going to be practicing at that time. And they really have to be able to take care of some pretty complex patients. Our patients are getting more and more complex, both medically and psychiatrically. And per US Census predictions, we are going to have an older population and a more diverse population, among other things. So again, our residents have to be ready for that. And we also, our program director, national organization called ADPERT, had a task force the past year or so. I was chairing that task force, and we came up with 14 guiding principles to help determine what the future of training will be for psychiatry residents. And I'm not going to go through all 14, I promise, but 3 that I thought were very relevant to what we're doing today, that we need to have specific goals for resident knowledge and skills in neuroscience-informed, interventional, and neuromodulation treatments. And it really is going to be our clinician scientists who will develop these goals, and they will teach these particular interventions. Residents should really be equipped as lifelong learners and be able to keep abreast of all of the latest research that is coming out. And it will be the clinician scientists who develop and teach these evidence-based modalities. And residents should be equipped to lead interprofessional and collaborative care teams. And we know here at the University of Washington that we are the leaders in this, and that our clinician scientists will teach collaborative care. So our trainees now, who are clinician scientists, they are going to train the next generation of physicians, of psychiatrists and scientists. They will be the academic leaders, like chairs of departments, deans, and dare I say, program directors. And they will start companies that will develop and innovate new treatments. And who knows, like some previous psychiatrists, they may win a Nobel Prize. So thank you so much for the opportunity. And I'll just leave you with a little quote that I like to think of, that, the care of the most vulnerable individuals, those with mental disorders, should be a vital sign for our overall health of our and culture of our healthcare system. Thank you.
So thank you for that wonderful perspective from somebody who is spending all of your time on our next generation, on training our next generation. So thank you so much. So now I think what we're going to do is we're going to have a chance. Like I said, we actually gave 10 training awards to clinician scientists in their training, and we're going to have opportunity to hear from just a few of them. Jesse, do you want to come up here and just introduce our 3 presenters?
Yeah, happy to. Our first presenter will be Catherine Liang, and she's a fellow at the VA's Mental Illness Research, Education, and Clinical Center. and will present a really innovative study that will shed some light on PTSD treatment. Catherine?
All right, thank you, Jesse. My name is Kat Leong. I'm honored to have the opportunity to tell you about my first actively recruiting clinical trial, the BRIGHT study. The title of my talk is Gaze into the Future, an Eye-Brain Connection for PTSD Biomarker Development. So this project arises from a high clinical need for research in PTSD treatment. To date, there are only 2 FDA-approved medications for PTSD, sertraline and paroxetine. Both of these are SSRIs, or serotonin selective reuptake inhibitors. They act on the serotonin system, which is a neurotransmitter that is involved in a lot of mental health disorders. They unfortunately have somewhat limited efficacy in PTSD, but they do work really well for certain people. The problem is, how do we figure out which patients respond to these drugs? Many patients suffer through years of failed treatment trials before they find a medication that works for them. If there was a quick test that we could do upfront to develop a personalized medicine treatment algorithm in mental health, this could have a huge impact on alleviating burden on both patients and clinicians. So there's a push in psychiatry now to develop biomarkers to help guide treatment decisions in mental health. So this project takes advantage of known connections between the eye and the brain that I used to develop a hypothesis-driven basis for developing a retinal biomarker in the mental health space. So let's take a look at the connections between the eye and the brain that formed the basis for this project. So I'm looking at you guys right now. You guys are looking up here at me. This is light signals that our retina are picking up from the environment, and the retina translates these light signals into electrical signals that project to the brain, and our brain interprets these signals as vision. There are also reciprocal connections from the brain to the eye that control all sorts of things, eye movements. Your pupils dilate and they constrict. But is there more? I looked into this more. There are actually direct projections from the serotonin centers of the brain into the retina that modulate retinal activity. So this formed the basis for this project. We can measure the retinal signals, electrical signals from the retina with a recording called an electroretinogram, or ERG. That we shine a bright flash of light into the eye. The retina picks up this signal. There is an electrical signal that the retina uses to convert the light into an electrical signal that gets sent to the brain. On the right, you can see the waveform that the retina is giving off. And there is actually a pilot study that has been done in patients with depression, where they used the ERG to start to try to develop a biomarker that might predict treatment response. So in this study, they showed that the amplitude of the B wave here, so the amplitude of part of the electroretinogram signal, was actually higher in patients who ended up clinically responding to the antidepressant versus those who did not. So you can see on the left-hand side, those are the people with depression who actually responded to the antidepressant. When you did the ERG at baseline, the amplitude was higher in those patients than patients who did not respond, as well as higher than healthy controls. And after 12 weeks of treatment with the antidepressant, that amplitude normalized to look more like the healthy controls. So the BRIGHT study, biomarkers in the retina for prognosticating mental health treatments. In 2023, I got a VA pilot grant to start this study, a $50,000 grant. The CSTP award, generously provided by the Garvey Foundation, funded the follow-up portion of the study that actually allows us to track treatment and clinical outcomes with the initial recordings. I presented the protocol for this study at a national conference and wrote and got our IRB protocol approved. So far this year in 2024, this month, we started active recruitment. We have a goal of 27 participants for this pilot. And as of this week, we actually had 7 veterans expressing interest and 1 veteran potentially meeting criteria for consent. And I'll be presenting this project at another national conference this year. So next steps. This really the big goal for this is to build pilot data to be able to fund, apply for larger grants to fund larger clinical trials to further develop this technology in the mental health setting. Potential impact on the field, if successful, this project has the potential to have great impact on the way we practice psychiatry, benefits for patients, families, physicians, as well as increasing our knowledge of biological mechanisms underlying PTSD that could potentially lead to new treatments. So in acknowledgements, of course, we all want to thank our parents. My mom in particular was actually a huge inspiration for this project in my career. She's blind. All of my PhD work was in the retina. I did ERGs in mice. Ironically, now that I'm a psychiatrist, I'm still doing ERGs in humans. I saw the error of my ways and decided not to become an ophthalmologist and become a psychiatrist instead. So very excited. I've just always been really inspired by the eye. So I'm excited to do this project. And I could not have done this project without the mentorship of Rebecca Hendrickson, as well as everybody in the Hendrickson group. Erin Rosser is the study coordinator for this, as well as a whole host of other mentors. I know I'm running out of time. So all of the funding, and of course, a final thank you to the Garvey Institute for funding this project and the opportunity to talk with you about it today.
Thank you, Kat. And we're all very happy that you went into psychiatry instead of ophthalmology. Our next really interesting study that you'll hear about is from Daniel Fisher, who's a fellow at the Alzheimer's disease training program. And he's going to tell us about a really interesting kind of cross-disciplinary study in Alzheimer's disease. Dan?
All right, I'm very excited to be able to talk to you guys about dementia and about psychiatric symptoms that develop in dementia, and about my project about how depression is different in dementia with my mentors, Dr. Michael Schrift, who told me not to point at him or he'll duck, and then Martin Darvis, who's actually busy in the lab right now doing work. So when we think about dementia, and especially when most clinicians think about dementia, we often think about cognitive symptoms, memory loss, language problems, inattention, difficulty making decisions. But the smart clinician knows that there are signs in the whole body that things are wrong when you have neurodegeneration, when you have dementia. Things like changes in vital signs, movement problems, new tremors. The really good clinician, though, knows that actually all these things in purple can happen specifically for people in dementia. These are all the psychiatric symptoms. You guys can pick your favorite. All the psychiatrists can find the ones that they work on in the room, because almost every psychiatric symptom can happen new onset in dementia. Over 90% of patients with Alzheimer's disease get new psychiatric symptoms. These lead to an increase in costs of about 50% for those who have these psychiatric symptoms versus those who don't. They're very challenging to treat, and they often are the reason why people lose their independence early, even when they are cognitively able to take care of themselves. Quite frankly, this is a disease that we need more psychiatrists researching, so I'm very proud to have the chance to do that. And I'm going to talk to you guys a bit more today about depression. So one thing I think that's really important to realize about depression is that it is incredibly ubiquitous. And I'm going to show you some data that we've started with from a national study with over 170,000 different patient visits. So for those who didn't have any cognitive dysfunction yet, you can see that, oh, I do not know why things are accelerating on the road. You can see that people had a relatively normal rate of depression for the population, somewhere around 10%. But as cognitive impairment came on board, these numbers got higher and higher. And then even when they switched into the phases of dementia, where they're often having trouble reporting their own symptoms, depression is still there at relatively high amounts. And these are probably underestimates because of the healthiness of our population. The other part that's really important, people who had depression presented about 2.5 years earlier and said they had cognitive decline. So what this might be is this might be a sign of the whole brain degenerating and affecting more than just cognition. Because believe it or not, the brain is where emotion lives as well. What's really important to know about depression and dementia, I think, from a treatment standpoint, is despite there being multiple clinical trials for most of our normal antidepressants, they don't work in patients with dementia. They do not separate from placebo in the same way that they do for other people. So depression and dementia is different. And the question is potentially, what is it? Well, what we hypothesize with this project is that the peripheral immune system is actually playing a role. It's now been shown that the peripheral immune system, especially things called T cells, can infiltrate the brain in neurodegenerative conditions and promote atrophy. And without these T cells, you don't get the same loss of brain tissue. And so we think potentially they're playing a role in creating these depression symptoms. And so we're going to study this with two different experiments. So the first one, we're going to take blood from this large cohort of patients that I've already talked about, and we're going to look at the peripheral immune signals, things called cytokines and chemokines. These are the things that signal pro-inflammatory and anti-inflammatory processes. And we're going to see if it's different in people with Alzheimer's disease who either have depression or don't. Then we're going to take a look at the immune responses of the individual cells. So we're going to take this plasma or these blood from these patients and put them on healthy immune cells from an older individual and see how those immune cells respond, because it's already been shown in otherwise healthy people with depression that there are subtle changes, and we expect there to be a lot more in this particular population, hopefully leading to either a biomarker to help us figure out if this is happening and separate it from other psychiatric symptoms, which I don't have time to talk about right now, but also to hopefully inform new treatments to see if immunomodulatory therapies can be helpful. So I really want to thank the Garvey Institute for Brain Health Solutions. You guys were seminal in getting this project started. We've now been able to expand it to different applications. So I'm now going to be sending in my K Award, which is sort of the building block for an independent physician scientists. And that's directly due to some of the preliminary data we've gathered here. And in that K Award, I'll point out Dr. Suman Jayadev, who's in the audience, as well, is going to be a mentor. And then, of course, I'd really like to also thank my clinical mentor, Dr. Kimiko Demoto-Riley, who's taught me everything I know about dementia and helped me sort of think through these projects in the very earliest of stages. Really excited, and this money that I got through the Institute is really the building block for all of this. So thank you.
All right, thanks, Dr. Fisher. And finally, we're going to hear from Dr. Nguyen, who's a third-year resident, who's doing a really interesting quality improvement study that's really going to get at trainee well-being and health that I think is really important when you think about the development of trainees and their eventual entry into a faculty career. So Dr. Nguyen.
All right. Hello, everyone. My name is Hai Wen Win. I'm a third-year psychiatry resident here at UW, and I'm honored to be here today to talk about my project. Let's talk about adverse events. So just giving you a little bit of background on how this project started. The project started when I was in medical school, actually, when I experienced a patient death. And I remember it was a patient that was there for rehab that I was taking care of. Overnight, the patient basically decompensated and ended up dying rather abruptly. And the way that I found out that this patient died was that I actually overheard my senior resident talking about it with the attending. Neither the resident nor the attending actually ended up talking to me about it. And so I kind of just was able to hold it together by myself for the whole day until I went home, and I basically broke down crying. Luckily, I had a medical student that I was working with that I was able to talk with and debrief this event. And so after that, I decided that it would be crucial to create a training to teach medical providers how to debrief after adverse events, because we all experience this as medical providers. So just some data from our 2020 to 2023 UW annual surveys. Many of our residents experience adverse events in this short period of time. So up to 40% of residents being threatened by a patient or experiencing racism, sexism, or discrimination from a patient. In contrast, not all of these events are actually debriefed by colleagues or attendings. So as low as 42%, so less than half of these events are being debriefed by attendings. And just keeping in mind that during these surveys, we did not ask about what type of framework was used for the debrief or whether the trainee thought that the debrief was sufficient or helpful. In our 2020 to 2021 survey, we found that 23% of residents actually did not feel comfortable reaching out to their attending physician to discuss these adverse events. And so, so keeping in mind that there's no actual evidence-based, universally shared model for completing debriefs, and we as providers are not taught how to debrief with our trainees after these adverse events. So my project was creating a workshop that taught a framework called the Recover Framework that would help providers lead these debriefs in a structured way. Some of the potential benefits that we were hoping to target with this workshop was preventing burnout, improving patient outcomes, experiential learning by encouraging reflection on these events, and then reducing the second victim phenomenon, which is where providers experience trauma after they experience their patients having adverse events. So the research project itself is going to be evaluating the effectiveness of this workshop with 3 surveys. So we have a pre-survey that providers get right before they take the workshop, a post-survey immediately after, and then a delayed post-survey a couple of months after they complete the workshop. So we're going to be looking at the effectiveness of the workshop in increasing providers' knowledge of debriefs, attitudes towards debriefs, and the practice of giving debriefs after experiencing adverse events. We're also going to be looking at the data from our faculty and resident annual surveys to see if there's an increase in the percentage of events that are actually being debriefed. So some of the preliminary feedback from the workshop that I've given, this is from the R1 workshop that I gave. So, many of the residents believe that it was essential. It covered a topic that rarely gets formal teaching, and it's a very clear framework. I've been able to present this workshop to not only psychiatry residents, but also OBGYN residents and pediatrics residents. We also gave this workshop to all of the psychiatry faculty at the faculty retreat this past year. And I've been invited to give this workshop to the OBGYN attendings during their grand rounds. So in conclusion, I just want to thank all of my mentors, Laurel Pellegrino, Tom Soprano, as well as Sarah Choa for their support through this process. And of course, thanking the Garvey Institute for all of your support and helping me to fund the project and develop my passion in physician well-being. This grant will allow me to really objectively analyze whether this project will create an evidence-based framework for talking about these events afterwards. Thank you.
And thank you. And thanks to all 3 of our presenters. You got a little snapshot of some of the projects that we are supporting for our clinician scientists in training, and they were all quite different. And they're all really, really important. This last one, I just got to say, the work we do is really, really hard. And we don't remember, those of us who've been doing it for 20 or 30 years, that when you first start with that, it's scary. And when you have a patient who dies, when you have, a patient who is so disturbed that they assault you, that they're angry at you, that's really hard to deal with. And we can do much, much better helping our new trainees, preparing them for that, helping them with that when it happens. So there is the very cool sort of science that's under a microscope, and then there is very important human things that we need to keep in mind. And I think that's why this idea of a clinician scientist is really important. These are not the kind of things that somebody who's studying things under the microscope would think about, but they're really important when we're trying to translate the science into a way of helping people and families who are struggling with these problems. So thanks to all of you. So we have one more section for this morning. And I've invited a couple people to come and share some of the other work that we're doing as part of the Institute. And that is focusing on what we can do to help engage and support family members and caregivers of people who are living with mental health and addiction problems in the way we care for them. And that sounds obvious, like we should do that, of course, but it turns out we're not terribly good at it. And this is just more self-critical than anything. And I'm just going to share one or two observations about that. In my role as a department chair, we have clinicians providing services to people in 5 hospitals and dozens of clinics, and we do over 100,000 patient care encounters a year. And for the most part, we focus all of our energy on the person who is in front of us, the patient, the person who's living with the illness. We sometimes, sort of are aware of the fact that with that patient, as family members, our loved ones, our people who are caregivers, we don't really spend a lot of time thinking about, what do they need to help do that, because that patient is with us maybe for an ECT treatment, or maybe for a psychotherapy session, or maybe for, a chat about how their medication's working, and then they spend the rest of their week with other people. We're never going to have enough psychiatrists and psychologists and social workers to take care of everybody. So my vision is we need to have everybody part of the treatment team. And the most important person is probably the persons who are already close to that person. What do they need? What do they need to know? What do they need to be able to do that well? And what do we need to know to be helpful? And the story I will start with, and see if here is Todd here. Todd is here. Okay, Todd Crooks and Laura are 2 wonderful people who came into my life a couple years ago, after a really, really tragic outcome with one of their children who was a patient cared for in one of our hospitals. And we had a really difficult conversation about what happened. And one of the things I think that Todd maybe said to me is some version of, we brought you this person who was a family member, who was a loved one, and you did a pretty good job taking care of him. You treated him, but when we came back to pick him up, we really didn't know, what do we need to do? What do we need to know to carry on? So you did a good job with the patient, but we kind of felt like we weren't a big part of it. We didn't really know a lot. And that really made me think. And I thought, yeah, we could all do better by this. And when I'm thinking about our residents, we're teaching and learning how to be a psychiatrist is very challenging. How to be a psychologist is very challenging. It's scary enough to figure out, what do I do with myself and with the patient? But now you've got a family member, and sometimes bringing family members into an exam room can also be very stressful, because you realize, families have family dynamics, and everybody's got a different idea about what should happen with mom or dad or grandpa or a child. And then that session gets very, very complicated. So sometimes it's easier for us to just say, no, forget about it. I just want to deal with, the patient. So this is not easy work, but I think it's really important work. And so I felt like we should put some of the best and brightest we have here to working on how do we do that? How do we do it really well? How do we try out some things and see how that works? And so one of the ideas we had when we had the opportunity to build this brand new $250 million facility, I sort of said, we're a university. What does a university do? We're teaching people stuff, but we're teaching students. What if we created something, for now, we'll call it a Family and Caregiver Academy. So if we could say to a person, when you bring us your loved one, not only will we do our best to care for them, but we're going to give you the opportunity to enroll in a Family and Caregiver Academy. Maybe we'll teach you something. Maybe you'll teach us something. You probably will teach us something, and how do we do that so we can all together then have a better shot at helping a person who's living with one of these illnesses. So that's a long set up, and Molly Forrester, who is a wonderful team member, working with us in the department in the Institute, and Anna Ratzliff are taking the lead on making this idea of a family and caregiver academy become a real thing. So come and tell us about what you're doing.
We even dress alike for our presentation, so.
We're mind melded already.
Yes, exactly. So good morning. Yes, I'm Molly Forrester, and I'm a clinical social worker based in the Department of Psychiatry. Last year, I was here and presented on some of the patient and family support programs that we've already been able to start in our department, and had a chance to think about some of our hopes and dreams for the future. And so I'm really honored to be back here this year with my colleague, Dr. Anna Ratzliff, as recipients of a Garvey Innovation Grant that's going to help us hopefully bring some of our dreams into reality. We are really grateful to the Garveys and also another donor who is also helping us with their combined generosity, be able to partner with several of our department colleagues who are already involved in this important work. Okay. So we know from years of research that there are many benefits to involving family and caregivers in the behavioral health treatment of a loved one. And we know that when given access to reliable information, families are often better able to understand what their loved one is going through. Sometimes having the experience of having a mental health condition can be really scary, it can be isolating. And so these educational opportunities can really allow families to understand what their loved one is going through, hopefully build trust and restore bonds, strengthen family bonds. We know that family-focused programs can also provide opportunities to enhance support networks for families and caregivers, that they can also help with developing skills, learning about the latest effective treatments, and can help give access to really vital systems resources. And for people living with behavioral health conditions, we also know that there's a lot of great benefits to them. Having an effectively engaged family and caregiver network can often lead to identifying earlier identification of relapse, response to relapse, and can really improve patients' adherence to a treatment plan and hopefully, overall the better quality of life for them. And yet, despite all of this, we know there's unfortunately a lot of barriers that exist to engaging families and caregivers. We know that unfortunately, as we've heard a lot about today, there's still a lot of stigma and misinformation that can go along with having mental health conditions. This can lead to isolation and just fear, a lot of fear. And when we look at workforce training programs, reviews of workforce training programs, we see a high level of variability in terms of how or if providers are even trained in engaging with families. When we survey the workforce, people will say, I just really don't have a lot of confidence in my skills in this area. Or they might say, well, I don't know if it's my professional work, so I'm thinking it's another member of my team, and that leaves that work largely uncovered. And unfortunately, we know too that family engagement is just not something that is uniformly covered by insurance. And so in the scheme of how resources are allocated, unfortunately, these programs are often excluded. So when Dr. Ratzliff and I started looking at what we would be doing in this realm, we looked at a review of really what have families and caregivers already told us that they want and need when their loved one has a behavioral health condition. And so it's been being guided by these priorities that we plan to pilot a family and caregiver academy. And what we're hoping to do is leverage the patient care, research, and educational expertise of our department and turn that into an evidence-based training, skill building, and support program that's designed with and for families when their loved one is receiving care in the UW system. And we hope to create a model of behavioral health care where both providers, trainees can learn with and from the lived experiences of our patients and their families.
Okay, and I will just talk a little bit about our team. So we're not doing this work alone, which is pretty typical. So I just want to acknowledge we're working closely with some educational partners to really think about the instructional design. That includes Alan Goydix and my colleague, Melissa Farnham. And then we are also working with Charity Holmes, who's really the person developing the whole program, clinical program up at the new Northwest facility. And of course, we also want to acknowledge that the best thing about being in this department is that we have many inspirational and thoughtful colleagues. And so we want to acknowledge those colleagues as well as some of our community. We're hoping to partner with NAMI Washington, for example, in the development of this academy. So what are we actually going to do? When Molly and I first started talking about this work, we really were like, what's a piece we can take on in a pilot to really be a proof of concept that this is something we can build and actually deliver here. So we are going to do the parts in the bright purple there as this first part of building this academy, and that's the work that will be funded by our innovation grant. The first thing we're going to really do is try to build a website presence. And you'll see those little asterisks on there, meaning that a lot of what we're going to build out is actually going to be delivered online and self-paced. The reason that we're doing that is a couple-fold. One, we really think often we want that access to the information and those training and skills when patients and their families have time to do it. As a busy working parent myself, I think I can recognize that, if there's only one class at 1 o'clock on a Wednesday, that might be kind of challenging for me to actually get to. I'm often, busy in a meeting or seeing patients. So, we really wanted to start with building that as part of our foundation. So the website, we also don't want to repeat anything that's already out there and existing. There's a lot of great information out there already around what a diagnosis is, what are common things that you can do to be helpful. And often those families, when they're getting a new diagnosis for a family, they need some of that really foundational information, and we don't want to reinvent that wheel. But we do want to make it easier for them to find high quality information, because there's also a lot of misinformation out there on the internet. So we're actually hoping to have that portion of the website be kind of a curated place that people can come as a first stop to get high quality information about mental health disorders and their treatment. We're going to go a little beyond that and actually work on building out 2 pieces of educational content. I have a lot of experience developing educational programs that can be delivered online. And so I wanted to bring that to really build that for families. So the first one is really an orientation to a psychiatric hospitalization. We hope to use a lot of video, really kind of explain, what does this look like? I think, like the nice pictures that our previous speaker talked about in terms of the misconceptions around ECT that are out there, there are also those around what a psychiatric hospitalization looks like. And it's pretty much a black box to most people out in the community, is what actually happens behind those locked doors, right? And so thinking about, really, this is where you go. This is how people spend their day. These are the places that your loved one will be in, and the kinds of care they'll be receiving would be really, I think, very reassuring to people early in their loved one's stay. And then we wanted to start to think about building out actually some skills for that family, kind of as Dr. Unisser talked about. We often, take care of the person, but we don't give a lot of information on how can you help best support your loved one when they come home. And what I did when we started looking at this is really looked across a bunch of different diagnostic categories. So we treat people that have depression, we treat people that have dementia, we treat people that have psychosis, and really trying to think what is common across. There's a bunch of evidence-based interventions from families. What's kind of common across all of those that we could give as a foundational piece to families. And so this is going to be a very intro communications course. It's going to have content like how to communicate positive feelings, how to communicate negative feelings, very foundational pieces. But I think a lot of us don't actually get a lot of training in communication. So those will be the 2 pieces. Lastly, I just want to highlight, we're going to really integrate input from patients, families, and caregivers to the design of these interventions. We hope this will all be a foundation to go on and, with future funding, develop more diagnosis specific, or even collaborate with some of our partners. You'll be hearing about some work with psychosis patients in just a second. So I'll just briefly talk about, we'll have a pilot, so those pieces that I just talked about. And then, of course, because I'm also a scientist, I can't help myself. I want to know what this is actually, how this is actually impacting the patients and their families. So we'll be looking at really like, do people like working in this way to get information? And how much do patients and families, caregivers actually engage with that information? And we'll do that through surveys and interviews. We also hope to demonstrate that this actually is important for high quality patient care, and hope to look at rehospitalization rates for the patients whose families engage as well.
Right. So as we look at opportunities to expand and grow the Academy model, as Dr. Ratzlaff said, we're looking at ways to fund this. And fortunately, there's some new Medicaid and Medicare guidelines coming out this year that might allow us to bill for providers engaging in patient and family education and training. So we're excited about that. We hope to continue our internal partnerships, again, with colleagues who are already doing this work. We would love to, as Dr. Ratzlaff said, look at this being a foundation for future educational models around specific diagnoses. So we're excited about that. We also hope to expand some of the family and caregiver support and patient support programs we already have, like navigation assistance, because the system can be so complicated to navigate. We really hope to be able to partner with our colleagues across disciplines, nursing, social work, pharmacy, to look at training them in these models and learning from our patients and families. So in closing, we would love to hear from folks who have questions about the Academy idea. We're looking for people to give us feedback on the curriculum, on our materials, what we're calling ourselves. So if you have any feedback for us or just have more questions, please reach out. Thank you so much.
So thank you. So this is a different kind of pilot, but I think it has also a tremendous amount of potential to make a difference. And there, as Molly said, we'd invite any of you, almost everybody in this room is a family member or a caregiver, even if we don't think about it that way. So all of your thoughts, all of your input about how we can make this a successful, super welcome. All right. The good news is we're as with a lot of the other work that we're doing, we're not starting from zero. We're not starting from scratch. We actually have a couple people in our department who spend a good chunk of their professional careers thinking about, this very topic. And I'm going to invite Maria Monroe DeVita, who is a professor in the department, who's a psychologist, who is, done, and she and her colleagues have done some really smart work about how do we engage and help family members. In this case, it's a particular a program that she'll talk about, a family bridger pilot for caregivers of young adults and youth who are experiencing a first episode of a psychotic illness. One of the most devastating things that can happen to any family. And Maria is going to share a little bit about that work.
Thank you, Jürgen. Well, I have to say I'm absolutely thrilled to be able to talk about a project that has been a dream of ours since 2017. So that's 7 years that we've been talking about this dream. And that dream is that we can finally develop and pilot test a family peer support, so a family to family support care model for families who have loved ones who experience psychosis while their loved one is hospitalized. And not only during that hospitalization, but also during that critical time period when they transition out of the hospital and into the community. So that's what I will be talking about today, is this opportunity and also a bit of our formative work that we did to get to this point. But first, I wanted to acknowledge our amazing team, project team, including my colleague, my close colleague and co-principal investigator, Akansha Vaswani-Bai, Dr. Akansha Vaswani-Bai, as well as our close colleague within the Spirit Lab, Dr. Sarah Kapelovich, who is a co-investigator, and our fabulous research coordinators who are here today supporting us and cheering us on, Whitney Hintz and Mackenzie Tennyson, and our colleague over on the other side of the state at Washington State University, Dr. Duni Olawoya. All right, so let's level set a bit about the current challenges at hand. And some of these descriptors will be pretty similar to what you've heard, but this is very specific, again, to psychosis. So we know that despite
lots of treatment advance in the area of psychotic disorders. They still remain among the most costly and most disabling conditions worldwide. So we see higher rates of suicide, incarceration, unemployment, difficulty with housing stability, as well as longer term and poor health outcomes, as well as even decreased life expectancy. We also know that the impact on families can be incredibly devastating, as Jürgen alluded to a minute ago. Some of the outcomes can include increased depression, anxiety, other challenges to their mental health, social isolation, which I think social stigma often contributes to and compounds, as well as caregiver burden and burnout. One study found that families can spend the equivalent of at least a half-time job in caregiving activities. And I think our discussions with many families about this, they would even tell you more than that. They really are the frontline workers in this area. Yeah, we also know that, especially in the area of psychosis, that involving family caregivers can have a profoundly positive impact on their loved one's recovery. You can see the myriad of different benefits here that are the counter to many of the negative outcomes I mentioned a minute ago, such as better treatment outcomes, fewer hospitalizations, even reduced mortality risks. And yet, despite the fact that both international and domestic treatment guidelines for schizophrenia recommend family interventions and family engagement in treatment, we find that many families are left alone. They're left alone to navigate how to help their loved one with psychosis, and they're left alone to help themselves. And this is particularly true when their loved one is hospitalized, a really scary time that many families describe, and one of the hardest times that they will experience over the course of treatment. So our solution and approach has been something called Family Bridger. It originated out of this idea of a peer bridger, which many of you may be familiar with, that is already in our service system right now, where a person with lived experience with mental health issues themselves is then able to come talk to patients on the unit and provide support to that patient. So it kind of came out of that particular area. And we were able to develop a blueprint for what this family bridger model would be by talking to families across Washington state. We talked to about 60 families and asked them the question, like, what would be helpful to you, or what would have been helpful to you when your loved one was hospitalized? And what would you recommend? And they told us 5 different areas. They told us they wanted better skills. Some of the communication skills that Molly and Anna talked about a minute ago, also just to better understand and use kind of cognitive behavioral kind of informed skills to be able to address some of those symptoms of psychosis themselves, not to be junior clinicians, but to just be able to understand sort of how best to communicate with their loved one when they were experiencing those symptoms. Emotional support. So having someone really be able to look at them in the eye and say, I have walked in your shoes. I know what's happening. I've been there myself, to offer support, but also a sense of hope. Education. And I think you all hit the nail on the head in the last presentation about there's just a lot of bad information out there. And so rather than being left to just Google the term schizophrenia and see lots of those negative outcomes I shared at the very beginning, but to really be able to provide, again, that sense of hope and have it based in reality and some of the positive things that are going to be happening in that area in the future. Advocacy, and that includes getting people involved with better understanding how to navigate the system. And with that comes access to resources, whether they're material resources in the community, but also access to resources like social support in their communities. And again, all of this being provided by a family member who has lived experience themselves with supporting a loved one who experiences psychosis. So that was a fun idea until COVID hit. And then no one would let us get even close to any hospitals during that time. And so we decided a couple of years ago to go ahead and pivot for a bit, and at least we could kind of pilot test and develop, get a sense of kind of the feasibility and acceptability of a family bridger model, that blueprint I shared with you a minute ago. And so we engaged New Journeys programs. This is a program, a team-based program that focuses on addressing the needs of individuals and families who experience first episode psychosis. Very different setting in the community. These are families that are already engaged in care. But again, I think just to be able to get a sense of, okay, what is it that we need to further build out with this model? And then how does it work to then recruit family bridgers? And what were their training needs? What were the consultation needs? How do we want to kind of build this out going forward and develop a curriculum to support these family members going forward? So we trained 3 family bridgers who had previously been trained in the Psychosis Reach, CBT informed skills model. We recruited 11 families across the New Journeys network. And over a period of about 12 months, we offered telehealth or phone contacts for up to 10 sessions over about 20 weeks. So 5 months per family, we were offering this family bridger model. And what we learned is that it was a pretty feasible and acceptable model. We found families reported a better understanding of mental illness after, better understanding of resources available to them, as well as resources for their loved one. They believed that they had an ally in the mental health system supporting them. They reported being more confident in their abilities to support their loved one and better communication with their loved one, as well as having better coping strategies to deal for themselves. Again, that kind of self-care and support part of it. We also found that they reported high quality services across those different components of the family bridger model. And all of them recommended that they said that they would recommend this program to other families in the future. So we felt pretty good about that and decided to go for a grant with the Garvey Institute. And we're really excited. Thank you, Garvey family, for offering us this opportunity to actually pilot test in the very setting that we originally had planned for. We will be launching in the 2 inpatient psychiatric units at Harborview and working with the Harborview team. And I don't expect you to read all of the wording here. Basically, the summary of what we will plan to do is to adapt the program specifically to an inpatient setting. Since we didn't get that opportunity, there are quite a few different nuances. And in many cases, these are families and individuals who are not necessarily engaged in care, which will be very different for this particular pilot. And we'll take a look at many of the similar areas that Anna and Molly talked about in their program. We'll look at feasibility, practical utility of the model, acceptability and appropriateness, and also some preliminary effectiveness outcomes of having family bridgers in that inpatient setting. Next steps, we're so excited to work with our other Garvey Institute colleagues. Many of the resources that Anna and Molly shared just a minute ago are perfect for us to have family bridgers potentially have access to. Rather than reinventing the wheel, we wanted to make sure that, whatever websites and materials, thinking about what to expect when somebody is hospitalized. We don't need to be developing some of those resources separately, but can kind of pull those together, and then we'll apply it more specific to this population in this setting. We also want to secure future funding. So we will be looking at grant funding as well as looking at private funding, specifically to better sustain it. Over time, we know that the peer bridger model is a Medicaid reimbursable service. And so that's kind of one angle that we would like to pursue in the future, is to have this be a Medicaid reimbursable service. Those peer bridgers are trained and certified as peer specialists in Washington State. And so thinking about, okay, what is needed in that sort of state system to be able to train families to support their loved ones specific to, again, addressing psychosis and potentially other areas. I think this is a model that we could really potentially use across diagnoses as well. Thank you to the Garvey family, and thank you for the opportunity to talk with you all today. And I'm happy to answer any questions at any point. Thanks.
Thank you for sharing, Maria, and for, I think, this work, which is really exciting. I know you guys were excited to do it, and then the pandemic came and nobody would let you get in the hospital. I'm really excited to see how this goes. I know we're going to learn from it. And you ended up on resources. everything is competing for resources. I think when we come out and we make a strong case that this makes a huge difference in our patients' lives, we're going to be in a much better position to say to state funders, to federal funders, to insurance companies, this is a real job. Somebody's going to do it. Let's find a way to pay them for it, because we are not all of us are fortunate to have all of the time in the world and all the money in the world to do this really hard and really important work. So but I think before we get there, we're going to need to make a strong case that we can really make a difference with that. Our last presentation today was going to be one of our newest faculty, Dana Duringer. Dana is, I think, home taking care of a sick child today. So what she came to the Garvey Institute for is the idea of, we have the largest psychiatry training program in the country here. We're training people to do all kinds of interesting things to help a patient, but we're not yet training them in how to work with family members. So how do we teach them the skills they need to do that really well? And I think that's a great foundational investment that we're making. And I think Anna has agreed to come up, and Anna is going to mentor a little bit on this project. So she's agreed to come up and tell us a little bit about what that looks like.
Yeah, so I just want to acknowledge this is all Dr. Deringer's work. I'm really excited to support her in this project as someone who's also very passionate about our educational program here and supporting our residents and really being able to develop new skills. So I think her work is really interesting in that Dr. Deringer is also trained in palliative care, and I think her passion for really being able to have complex conversations comes from that background of being both palliative care trained as well as psychiatry trained, and really realizing that often individuals facing serious mental illness and their supports, their families and caregivers, describe wishing they had better communication with their providers, and that they actually, unfortunately, as Dr. Unitzer said, many of us are not formally trained in how to do this. There's a lot of mentoring and a lot of observing and being able to see that modeled and then repeat that. But there are now really strong frameworks that we could actually be delivering to our trainees. And so we think that this is really important because we don't want individuals that are impacted by serious mental illness and their caregivers and families feeling unheard or excluded, not feeling like they're really able to participate in their care. And that actually this is a missed opportunity to deliver recovery-oriented, patient-centered care, and also to have our providers feel more confident and able to engage in these challenging conversations. So what she wanted to focus on is really one specific type of communication that is really common during an inpatient hospitalization, which is a family meeting. So as a provider, a psychiatrist, you often are meeting with that family as you're getting closer to discharge. And that's kind of a one-time typically opportunity to really help shape the understanding of what brought their loved one into the hospital and what are the things that we're really recommending to help support them as they transition out of the hospital. So what she's actually going to do is develop a formal curriculum for our first year psychiatry residents. So right when they come in, really be able to get these skills. And they're going to be right there able to apply it because they're doing their inpatient psychiatry training at that time. We're actually going to hopefully get this built out in our online educational portal, so we have that available. So also trainees can come back to it when they maybe 3 months down the road have to have another one of these challenging conversations, and then wants to really understand a little bit about how this will help people feel more empowered to do this work, as well as feel more patient-centered in their care delivery. She wants to acknowledge all of these wonderful collaborators. I think you can see the 3 projects today are planning to work closely together. Okay, so let me just make sure, right, okay. So next steps, this first part of her project is to work on building out the curricula. We've been talking about that. really building some close relationships with the rest of the team that will be supporting these family meetings also, and also wanting to get input from patients and their families around the materials, the curriculum that she's developing. This will actually be delivered to our brand new incoming class that's about to be matched in the next couple of weeks in July. And then she'll be working with them to practice those skills in their clinical work. The hope is that this will be something that will become a routine part of our training program, and that there might be the opportunity with this grant to actually develop further interprofessional colleague collaboration and training for the whole team. So Dana is doing some amazing work, so I hope we get a chance to hear more about how it goes.
Thank you, Anna, for giving us a little glimpse of what we're doing there. So it's probably been too long for me to remember, but I am pretty darn certain that nobody ever talked to me about how do you do a good family meeting when I was training in psychiatry. You know, you would think that, you know, that's something that's pretty obvious, but it's not. And some of us get good at it over time. Some of us, you know, some of us never get very good at it. And I'm excited because, you know, we're going to recruit a new class of residents who in their first year of training are going to get some real focused attention and skill on that. And then we'll see, you know, what we can do with that. All right. So I think maybe, you know, a couple of closing comments here. First of all, thank you all again for everybody's contributing to this effort in some way. You know, and I think, you know, there is that thing that says it takes a village. I think we are building a really, really neat village here. We have, you know, people who are got the talent, the skill to really understand what's happening inside someone's brain. You know, we have hundreds of billions of neurons that talk to each other in complicated ways that then result in how we feel, how we act, how we think, how we behave. And as we start getting a better understanding of that, how do you apply that knowledge? And then we have on the other end, you know, all of that human stuff, which is, you know, that's all good to have all that great knowledge, but how do we take that and help people in a way that makes them feel like people listen to me, you know, and I think when it all comes together, it's going to be really, really exciting. So before we break for lunch, I have invited a couple people who are here today to just share a few reflections, maybe on the family and caregiver part, but maybe anything else that you heard today that you want to share with us. And I have this mic here, and it's not working, so that's good. Let me see if I can make it work. Okay, great. Who knows how to make this mic work? Yeah. Okay. Yeah, no, I did. Okay, all right. All right, that and the parking. So we got stuff to improve for next year. All right, so I'm gonna pass this mic to two of wonderful people and great supporters of our department for years, and that is Frank and Elise Katz, and I've asked them to say a few things about what we heard this morning.
Thanks, Jürgen. So first of all, I'll stand up. So first of all, my heartfelt thanks goes to Maria and Akancha and Molly and Anna and Dana, who I've never met. As a family member, I just want to say that it's so important. I'll go back to just quickly, the moment that the very first time our child was taken to an ER because of erratic, unusual, confusing behavior, we had no idea what was going on. It then led to them telling us she was going to be going to an inpatient unit, which I had no idea what that meant. So here we are, we go to an inpatient unit, and soon she's taken away and the door locks. They locked the door, they locked her in, but as locking her in, which I had no idea that was going to happen, they locked us out. So this program is so critical. These programs are so critical to the inclusion. The understanding is just immense. So thank you all for hoping to improve this area of psychiatry.
So I also want to thank everybody who's here and acknowledge some of the changes that have been taking place. I saw Ryan Kimmel when I walked in. I don't see him now, but I remember trying to get a family meeting for our daughter after an extended period of time in the hospital. And the change that has taken place, and I particularly want to take a note of what Jürgen touched on and Maria touched on later, which we've always thought of this as taking care of the families. But there's very, very clear evidence that taking care of the families takes care of the patient. The patients do well. You know, I can only imagine what it's like to be locked in a unit and, you know, the doctor walks in and says, you know, here's a medication I want you to take, and here's the therapy I want you to go through. And they're already in an endangered and a difficult state. By coordinating and preparing the family to support the patient, you're really helping the patient. And under Jürgen's leadership, there's been a pretty dramatic change. No, there's been an incredibly dramatic change here in the 25 years, I guess, since the first time we were locked out of that unit, which wasn't actually here. It was another local hospital, but we were soon locked out of here too. So thank you, Jürgen, and all of you who have participated and are continuing to participate to take leadership in affecting change in these areas. Thank you very much.
And then thank you for your comments, for your tremendous support. And actually, if you could pass the mic right behind you, Jesse, I've asked Denise if she'd be okay with saying a few things.
Sure. Although Elise has given me PTSD, I too have been locked out of the hospital multiple times. So, and I just want to tell you how inspired I am by all of you guys today and all of the progress that you've made, even in the last year. So it's really, really heartwarming and amazing. And the only thing I have to offer about the family connection and I'll just share this, that and all of the contact I've had with caregivers or caregivers at hospitals throughout the last 7 years. There's one I remember the most. The ones that I also remember, but with more pain, is the you know, this is a you know, I did a cognitive test on your son, and you know, this is what's wrong, and this is the one I remember the most is the start of the conversation was, I just want you to know that your son is the kindest, most gentle human being. And you know, just them recognizing that his humanity was so, so important for me to hear. I'll never forget that.
Thank you. So I'd love to invite all of you to share your thoughts. Maybe we should do that out at lunch. We do have a couple of our advisory board members here. I wonder if any of you want to share any quick comments about what you heard. Ken, you're back here. I'm going to give you the mic.
Yeah, thank you, Jürgen. And I'm really going to reiterate a couple of these comments. First of all, as a family member, father of a daughter who also was in inpatient care multiple times, it's a little PTSD for me, the locked out piece. The first time that happened was during COVID early, and I didn't know what was going to happen. I didn't realize the last time I was talking to my daughter, I wasn't going to see her for weeks, and that was really, really hard. So the work that all of you guys are doing on that is important, and for me is super inspiring. But the whole morning, three things. I just start with unbelievable gratitude and appreciation for the work that everybody's doing. It's inspiring to me from the outside to have an opportunity to see a little bit more on the inside of how hard the passion and what you're doing. And the second point, the second emotion for me is optimism. It's easy. I'm very optimistic today. My daughter, who went through a very, very difficult time, is now behavioral neuroscience major at Northeastern and is thriving. And it's because of the work that everybody is doing in this field that comes together and does that. So, but hearing today, I'm more optimistic than ever about the future of what you're doing. And the third thing is, the third emotion I have is confidence. It's not just optimism because I hear kind words and positive thinking. It's optimism because the approach that's being taken of cross-disciplinary work, hard work that starts with an idea that goes to a pilot, but with a focus on how to get to scale so that you can target populations. And the evidence is here that you guys are making real progress on it. So it gives me just tremendous hope, but based on a confidence of the capability of this team and this group and your efforts. So thank you very much.
Thank you. Joe, anything you want to share with us? This was not rehearsed, so.
Yeah, I'll be super brief. I think you all know, or at least I hope you know, how important the work you do is. But I think one of the changes we're seeing is families and institutions are starting to understand how important your work is. And I was struck last year by the statistics of we will never be able to train, or you will never be able to train enough providers for the need that is out there. And so these scale solutions you are all coming up with, and these integrated solutions you are coming up with, gives me hope that, you know, there's so many of these unmet needs, especially outside of these cities, will be able to be met more easily. And then it is just fascinating for a non-scientist to just understand the rigor of the research, but the progress in this field in particular over the last few years. And so just compliments to all of you. And you don't always get to see the results of your work as quickly as the physicians who are treating physical medicine types of treatments. But boy, is what you do probably the most important thing that we can do for humans. So thank you for everything.
Well, thank you. So again, one more big thanks from me to all of you. It's wonderful to see you all here. I mean, I'm going to be totally biased about this. We made a pretty bold promise a couple of years ago. I think we really are well on the way to trying to meet some of those goals. And I just want to thank everybody here for your contributions. I know a bunch of you are on Zoom, and thank you for all you do. We are happy to hear from any of you, any suggestions about if we're going down a path that doesn't sound like it's going to get us very far, tell us about that. You know, I believe in failing fast. So if it's not the right way to go, we want to know. If you have any thoughts about anything we are not doing, anything we could do better, anything we do smarter, let us know. I think we have a tremendous opportunity here over the next couple of years. Times really are different from some 30 years ago when a couple of us started in this business. You know, people have woken up to the fact that we have a mental health crisis. Every time you open up a newspaper, you're going to read about the mental health crisis we're in. Now we just need to wake up to the fact that we need to actually do something about it. You know, but even there is some progress. You know, we are about to open up a brand new facility that really is a dynamite state-of-the-art facility. $250 million of taxpayer money went into building that thing. So I also have hope, I have optimism, and I just want to thank all of you. So we're going to do this again, hopefully in a year, and you can see if you were here last year, a lot of stuff happened in a year. We'll see what happens by next year. What we're going to do now is just adjourn here. We're going to have a lunch that's served in the far end of the room upstairs there. So please join us for that. Talk to each other, meet each other. And for those of you who are interested in the nuts and bolts of setting up a research center here at UW Medicine, we'll share some ideas in a workshop at 1 o'clock. Thank you.